Hello, everyone. Good evening, and welcome to yet another episode of ICPA Clinical Series. The theme of ICPA Clinical Series is each episode one clinical challenge, and today we have the 21st episode. And I consider it my great privilege and a great opportunity for us to invite our today's guest speaker, Dr. Sourav Banerjee, a pioneer in microscope enhanced dentistry in entire Eastern India since 2010, and he's also the first in Bihar and Jharkhand. He completed his BDS from Sharavati Dental College, Shimoga in Karnataka, and he also introduced the brand Endo Concept, where he became the first person to start training in microdentistry in Eastern India. We'll hear it from him more about it from him. And so far, he has conducted over 90 CDE programs under the banner of Endo Concept. He's also the KOL for multiple companies like Money Japan, Kawokar, and many more. And he has taken his advanced training in multiple subjects, including medical microbiology from Manipal University, and most importantly, Micro-Endodontics from Buffalo University. So, welcome, Dr. Saurav.
Thank you, sir.
It's a great opportunity to have you with us. Before you start with your presentation, where you are going to talk about evidence-based microendodontics, I would like to know more about your educational experience in Buffalo University, where you studied microendodontics.
So that was the first center where we came to we were made to work under microscopes, and it really opened new horizons. And we came to know that I did it in way back in 2007. So that time microscope was not very popular in even in India. So we came to know like how things can really matter if you work under that. Apart from seeing the details that is needed in a precision work like dentistry, not only in endodontics, entire dentistry, uh, the most importantly, like we are able to work comfortably, like sitting upright and seeing good images without stressing ourselves was the most important thing that we learned there, sir. So that
Okay,
changed a lot.
okay. And what was the duration of this program?
It was a 1 year program, sir.
1 year program. And when you decided to be a pioneer in your area for microendodontics, was there any concern or any anxiety that it is too early for this area? Anything of that concern? How did you take that decision? How confident
Uh,
you were that it will become very fast? Today it is doing very well. But how was it when you took the decision?
Sir, I would like to thank many people who helped me during that time in some way or the other. But the most important thing was like it was not easy decision, as because we know that when it comes to microscopes, they are not very affordable. So apart like in dentistry, it's very difficult to, and even in a tier B or tier C town. So thinking we always think regarding the ROI, but though I was also in the same dilemma at that time, but one thing that I learned there was if I don't start practicing what I have learned, I lose the touch completely. So that thing compelled me to incorporate the microscope. Though that decision there, I will not say the decision was wrong, but or right, but it was very difficult. But somehow we managed, and now what we have realized is having a microscope in your practice is not about just about ROI. It is more than that. It
Great,
is more. It's more than that. It gives you it's actually helps you to have a good health. That is very important, and also you give better to your patients. So it is not it. It is a more value addition rather ROI. What I mean to
great,
say.
great. So I think initial part is done. I'll come back again once your session is over, and we'll be taking the questions sent by people who have registered for the webinar, and then we'll take some live questions also. So it's all over to you, Dr. Saurabh.
Sure. Thank you, sir. So. Uh, Thank you, Rajiv sir, for that wonderful introduction and nice a preface to the topic today. So we'll be discussing about some evidences based microdontics. It is not exactly related to cases that we do every day, but evidences that why we need microscope, evidences how it helps us and how it helps us, even our patients, to get better treated by us. So the key points of today's discussion will be why we need a DOM, is dental operating microscope, and necessary in our clinical practice, understanding the deleterious effect of working in wrong posture, that is having on musculoskeletal system, understanding the limitations and the age related changes in our eye, and discussing few cases where DOM was the game changer. So this is the key points that we'll be following. Now, if I say dentistry is itself an occupational hazard, I'll not be wrong completely, especially when dealing with precision related cases, cases where we are um, working on areas that are in millimeters or sometimes even less. So it itself is occupational hazard where we uh, have to work in close proximity of the subject's mouth. Apart from the clarity, it is also making us prone to the communicable diseases. Just in COVID times, it was completely uh, it came relevant to us, like how dangerous it is working very close with the patient's mouth. Now, our procedures mostly include working in millimeters or even less than that, and working at distances away from our the subjects that are away from our eye. The things the eye sees a subject in the most detailed fashion where it is near the focal length. But if it is far from the focal length, we will be seeing the gross object or subject, but it will not be very clear. So taking a clear image in that condition again is it allows us to take a such postures which is not very friendly to our musculoskeletal system. And again, we keep on working for hours together, sometimes 6 hours, 7 hours, 8 hours, sitting in one posture, and this is again creating some kind of health hazard. Now, a very important thing is when we will be able to see, we'll be able to appreciate, then only we'll be able to treat. If we don't see something, it will not be in their mind, it will not be in our conscious, and we'll never think of treating it in some way. For example, let us consider this MB system of an upper first molar. So if I don't see this image, I think there is one single opening and that is round. I'll never think that this opening is keyhole shape. It is not even, it is not round. So once I see that area, I understand that is not what I am actually imagining. So it is like that. Now, when I don't see this calcification and that is narrowing this orifices of the canals, I'll never believe it. So once I clean and shape them, I realize no, these exist in this fashion. So we'll treat. There are a lot of examples. In time constraint, we can't discuss many, but just give an idea, like we can only treat that we can see. Now, when it comes to evidences, what is the um, problems that we face in our day-to-day practice. First group of evidences come from the musculoskeletal disorders and then the limitations of the human eye. Both of them, one thing is clear, that over 50% of the clinicians suffer from one of the other musculoskeletal disorder in their lifetime, or and they are eventually, as it advances, they become presbyopia. So presbyopia is a age related problem that is inevitable, that will certainly help to us, and these all are creating limitations. When we work on our patients, these are creating limitations for unaided eye, and most of the issues happen as because we want to see clearly. So when we attempt to see clearly and our eyes are not giving us sufficient details, we stress ourselves, we bend on the patients, and most of the musculoskeletal disorders happen that way. So that was just a prelude to my presentation. I want to give respects to my parents and begin the presentation. So musculoskeletal disorders. Evidences say that over 70% of the dentists develop musculoskeletal disorder of some kind in their entire lifetime. 55% of the dentists sometimes need to stop working or retire before the age of 67 because of musculoskeletal disorders. Now, what does this musculoskeletal disorders actually do? Now, when we have this musculoskeletal disorders, they will lead to loss of synergy. Now, a lot of synergy is what? When we are working on a patient, the eyes, the musculoskeletal system, and the conscious or the nervous system are working in tandem or in synergy with each other. Now, when we develop a issue with the musculoskeletal system, there is a loss of synergy, as because that link is the links breaks, and the link break as because we are working non-ergonomically or the lack of ergonomics in our posture. Now, the overall thing leads to decrease in efficiency. Now, when we say decrease in efficiency, maybe we'll be not able to work for long hours, maybe we'll not be able to do many patients, maybe whatever work we are doing, that is also will lose precision. Ultimately, the patients will also not get a good quality treatment. Now, when we talk about ergonomics, let us understand the meaning of ergonomics. Various dictionaries, when you go in the definitions, basically they say that whatever you do, it should be efficiently and it should be done in a safe way or add to safety. So overall, ergonomics can be summed up, that is synergistic efficiency with safety. So there will be a synergy between the eye, between the musculoskeletal system, the conscious, and overall it will add to safety of our own working so that we can deliver better job. Now, when we say musculoskeletal disorders, let us understand like what are the initial signs symptoms. So we certainly, many of us would have experienced this sometime or the other in our career or during patients. Now, this frontal headache or pain around the orbit, that is mostly due to straining of the eyes, constant staring at a close proximity. You can have low back or stiffness of the back and pain, stiffness of the neck or the shoulder, frequent episodes, ache or heaviness of the head, and sometimes even occipital headache. So these are the symptoms that our musculoskeletal system is getting stressed. So if you are having this, you need to take immediate steps to resolve the problem. Rather, you develop more aggressive uh, issues. Now, this is most of the time when we work in such posture that our head is bending forward, the most of these issues will slowly crop up. Now, limitations of the human eye. Now, when I say limitations of the human eye, we need to understand it is not a pathology. Now, human eye, as any other body parts, has some limitations. So it has a normal range of action, and there is inability to perform beyond that range. So it is a wonderful thing given to us by God to see this beautiful world, but it do have some limitations. When we stress this organ beyond its capacity, problems start cropping in. That we have to understand. Now, the when we have the problem of the eye, that is because of two issues. First one is the refractive power of the eye. Now, what is refraction? It is the ability of the eye to focus the near or the far objects. Because the crystalline lens is changed its curvature because with the help of the ciliary muscles, and your eye can focus on the near objects or your eye can focus on the distant objects. So this is the ability of accommodation or the refractive power of the eye. The second is the resolution. Resolution is the ability of the eye to see the details of the image. This happens because of the wide angle that forms on the retina. So when we focus on focus on a subject that is um, in the focal length of the eye, will form a large angle on the retina and the details could be identified. Now, that has a limit. We cannot, the maximum resolution of the human eye is 0.2 mm or 200 microns. We cannot resolve anything beyond that. Though this seems quite great, but when it comes to dentistry, it is not sufficient. Now, the problem that happens with the refractive power is the focal length, that is the normal focal length is 250 to 300 millimeters, that is 25 to 30 centimeters. As age advances, the accommodation ability of the eye decreases. For example, it will not be able to like create great curvatures in the eye. So when the lens will form less curvature, it becomes unable to focus on the near objects, and this tendency is known as presbyopia. This happens invariably when the age advances. It is with everyone. So the ability of the eye to focus on near objects decreases. Now, when the eye, as I said, the eye focuses best when the image is in the focal length. But imagine the eye is becoming more and more incapable of focusing on the near objects. So what becomes? It will not form large angle. So for a large angle, the image should be there in the focal length. But if it is not in the focal length, it is focused somewhere away, it will form a small angle and we cannot make out the what you call the details of the image, and such the resolution becomes much lesser. Now, what I call this thing is a seeing is believing. For example, this is our normal way of working, and suppose this is what we see with our unaided eye. A crown trial in the trying phase just before cementation, and we think oh it's fine. But just see this one. When we see through this microscope, we see a short margin there, we see a short margin there, we see a non-perfectly fitting margin of the crown there. So these things were not appreciated when we are seeing with the unaided eye. Now this is the difference. Now when we see this, next time will it strike our mind, no, there was a shortfall, perhaps I was not seeing something clearly there. So this is how it makes difference. Now let us see this exercise. How many lines do we see there? It could be many lines, but again it could be a one line, but we are not sure exactly how many lines. To give precision, we should be exactly knowing how many lines are there. So this is known as the resolving power. Now this resolving power you get with your enhanced resolving power you get with your what do you call your microscope. Okay. Now microscope gives us a detailed vision, and that too ergonomically. We sit upright in a comfortable position and our head is straight. We are observing, we are seeing straight. A patient is lying there, but we can see the things, the concern related, whatever is concerned to us, we can see that clearly and precisely. So that is the help we get with a microscope. Now let's visit the traditional posture, like how we used to work without unaided eye. Now this was that. This is the traditional posture. Now what is the problem with this posture is the back is aligned this way, the line of vision is this way, and finally the neck has to bend to meet this line of vision. So this is the problem. This bending of the neck in this posture is the greatest problem that will lead to many other issues. And in this one, we are bending in a lateral way. That means a too inclined bend of the spine that is creating the more of the problems. So this is the posture that is creating the problem. So why do we have to bend? First, of course, like why you are bending. So we have to bend, as I said, to see, like to get a magnified and clear view of the field. As I said, like when we bend down, the image falls in the like focal length of the eye, and you can see good images. But that is only till a limit. So partially we get a good view, but it is not sufficient. So why overall it is not satisfactory? That's because the resolving power of your eye is like it's fixed, it will not change, it remains unchanged, and the perception of seeing better is there, but we don't have a much clarity that is needed sometimes. And overall this ability goes down when your age advances. Like as I said, you will develop presbyopia. So this is thing we have to understand. Like a clinically relevant open margin is almost 200 microns. okay, which can be increased. If you are using a microscope, you can increase the resolution 100 times, so which is much more helpful. Now let us understand what are the flaws in the upper, like the posture that we have seen. The most important flaw is the forward head position. Bending the neck forward is the biggest of all the problems. Trying to gain a magnified view by moving close to the subject of concern. Again, you are moving close to the subject. Bending the spine in a lateral way, that is again a problem. And resting your feet on the not on the ground but on the ring of the, what do you call, you can see this ring of the operating chair is a wrong way. The posture should be right angle all throughout. So that is the right posture. You should not rest your feet on this ring of the stool, which is a wrong posture. So these postures we need to correct. It's very important. But again, when it comes to this, if you sit everything way, but if you want to see closely, you have to bend invariably. Can't help to get a better view. Now, how microscope helps? Microscope, it has a wide range of like working distance. So it increases the working distance from say 250, 300 to almost 400 or sometimes even more. So you have a better view of the area of concern sitting away from the patient and not bending. Microscope does all the work for you. So the resolution increases and the increased working distance. So these are the two ways which we were lacking in our, like the inability or say the limitations of the human eye are solved with the microscope. Now, the solution is incorporating dental operating microscope or dental operating say DOM and modify the way we work. We need to modify the way. For example, just compare this to images. Here, the person is bending quite to see clearly, but here the clinician is sitting straight. Now, what is the difference between this image and this image? We'll try to make out. Here, this is the line of vision, the neck, the back is straight, and this is the line of vision of the clinician. And here the like the rays from the concerned area is going. So we are not bending, we are sitting straight, but we can easily make out. Now here this bend was made up by the bend of this microscope. So this is how it helps you sit straight and you see your area of interest clearly and comfortably. You don't have to bend down. So this is how we should modify the way we work. Now let's reveal the role of resolution. We have already understood how resolution helps. We can see the entity's details. Now we'll understand how it really helps in clinical practice. So this was a case. You can see like much constricted canals there. So the clinician perforated here near the, in search of the mesial canals, they perforated, and it was some calcium hydroxide placed by the same clinician to identify like where the perforation happened. And this was the location of the perforation. Now in the like under the microscope, you can see there's a canal opening, and that's a bleeding spot or the this thing, the perforation. Now these two, the canal opening and the perforation were very near. So if I want to correlate it to something, I can correlate it to a 30 number plugger. So a 30 number plugger, if placed in this area, will almost cover both of them. So such near it was less than, I think, 0.1 or 0.2 mm. So it is impossible. But under the magnification, we can see, we can clearly separate them and see them as entities, as because it is important. If in this case we need to fix the perforation with a different material and a different technique, and the canal needs obturation with gutta percha and seal or whatever, so they both of them, the modalities are different, so we need to see them separately first. So this is after a clear image, and this is after obturation, and this is we seal the perforation with MTA. So to work precisely on both the entities, we need to see them resolved first. So that is the very important aspect that we gain with a microscope. Now, another case here. So this was again a failed root canal treatment. Now when remove the crown, we could make out a big perforation there in the floor. When the temporary cement was removed, a lot of clot could be appreciated. And here we can see after the cleaning now, perforation repair, one important thing is you have to clean and make that area like you should have hemostasis in that area. It's very important. The bleeding should, the oozing should stop. So once we do this, we can see that area very clearly. It was a big perforation. So we managed it with MTA and PRF under, but the PRF was like I couldn't control it. A bulge happened, but we had a good follow-up of the case of 4 years and still the tooth is working. So here again, this your microscope helps. Now, this is a wonderful case. Again, the example of resolution comes here. A case where a file was fractured, but retrieval attempt were done with loops, and there was a midroot perforation there. We'll see this case in detail. So this is the fractured file, and you can see the midroot. This is after the removal of the file. After you can see this midroot perforation there. Finally, the gutta percha was removed, and here clearly this midroot breach of the dentin wall can be appreciated. Now again, cleaning, shaping, and cone fit. Finally, now this is the important. Here is the perforation, and this is the canal. Now, if I don't say this to identically, I cannot treat them identically. I need to see them identically first. For example, if I am working with the unaided eye, I'll pack the gutta percha. It may go there, it may come here, or somehow I'll pack, but I'll not get a desired result. That's because the perforation, midroot perforation, is having one of the worst prognosis in endodontics. So if you need to treat a midroot, you have to seal that area with bioceramics. So that is most important, or MTA. So we need to see that identically first. Now again, we could treat them identically, and finally the entire canal was filled with gutta percha. More of that. Finally, clean chamber, orifice sealing. So this is how that helps. Like this final images, you can see that midroot area, the bioceramic is flown in that area, and there was a big radiolucency there. And 2 years follow-up, all radiolucency gone, and it's good healing, and the tooth is good in function. So again, resolution helps. Now, when it comes to, I have just added one case of broken file here. So just to like highlight the importance of resolution. Without resolution, this kind of cases cannot be done. Now, apart from the retrieval, this was a very different case. I did this case long back, and there was a mesial tilt in the 7 number tooth. The 6 was missing, and the 7 has a quite amount of mesial tilt, and the file was fractured beyond the curvature. So this is the canal curvature, and the file has fractured there. So there are a lot of challenges. The most important challenge was the mesial tilt of the tooth and the file beyond the curvature. So what we did is we thought that first in retrieval, the first rule is you have to see the file, otherwise it is very difficult to retrieve. So what we have done, we thought that this amount of the dentin has to be removed to make this coronal portion of the file visible. Now here in this like standard positioning of the patient, it was very as because the tooth was mesially tilted. Now it was almost out of line of vision. So we had to improvise the patient in a Trendelberg position such that somewhat the line of vision and the canal became aligned. Now if we remove a dentin from this portion, I think this will become visible. So we kept on, so this is the ensuring visibility and ergonomics. So we kept on working the same way. This dentin was removed, and finally the file became visible. After that, a 180-degree gutter was created on the inner wall with modified tips, and the file became loose. You can see there, the file became loose, and finally it came out. So this is without resolution, as we saw in the previous slide. Unless and until you precisely work on the inner wall, you will damage rather than will help. if you don't work on the inner wall, you will certainly land up in perforating the canal in the midroot area. So this is how it helps. And this is after retrieval, you can see the orifices there, this following obturation. And this is now almost 9.5 years, going to be 10 years. It is a very recent radiograph, taken a follow-up radiograph, and the tooth is going good in function, no problem at all. So this is also creating evidences like, now, this is a case where magnification helped us to not go for root canal treatment. Like otherwise, the case was such that, sorry, I'm missing the radiograph here, but the case in the initial view and also when you take pictures, the cavity deep seemed so deep that we needed a root canal treatment. Also, the patient was having a lot of pain. So in this one, magnification helped to not go for root canal treatment. We cleaned slowly with hand instruments, and finally you can just make out that pulp there. Complete hue, I think less than a of uh, uh, what you call dentin was left. Finally, we did it with following all the protocols for restorative dentistry, and then we placed the light pure calcium hydroxide, sealed with the GIC, finally flowable, etching, flowable, and then the restored finally. And the tooth is really going fine. So this is how it has reduced the morbidity. Now, studies, one important thing that we come to now, that the most important other causes of musculoskeletal disorder is that is continuous working. Now, of all the endodontists, over 80%, 88% represents with various musculoskeletal disorders. And this is mostly as because continuous working without taking break. So that is also one of the problems. In spite of, if you are working with microscopes also, you need to take frequent breaks. So if you're not taking frequent breaks, it's a big problem. So the answer is short breaks. Take 5 to 8 minutes of break between every case. So say a 40-45 minute case, you get up and do few stretchings. Now, what can we do? Now, there are two things that you can do for yourself. There are few exercises for the eye that you do. Now, what I'm saying, these are all between your cases. Exercise for the eye and exercise for the musculoskeletal system. Now, exercises for the eye, like you stare at like a green light. It is soothing to the eye. Green light for say about 20-30 seconds. Stare at a distant object very far in a relaxed way. Focus on a near and a distant object, like repetitions. Now, draw a big imaginary 8 with your eye so that all the muscles of your ocular and extraocular muscles are involved in that one. Then blink frequently. The most important thing is when you're working, we're constantly staring, we're not blinking, and that like breaches the lubrication of the eye. So frequent blinking is very necessary. And close your eyes for about 20-30 seconds, and rubbing around the eyes helps, like it increases the blood circulations and the lymphatic drainage also. Now, exercise for the musculoskeletal system, the most important body parts that is involved is your wrist. So you have to take good care of your wrist, exercise them, stretch them, exercise the neck, round rotation, sideward movement, stretching, and all those things. Exercises for the back, get up and you can have like stretching of the back, and exercise your shoulders. Like, so these things between the patient, it doesn't take much. It takes for 5-8 minutes before the patient readies the like your clinic for the next patient, your chair for the next patient. You can just finish off these things. These are essential for you to function. So summing up, modify the working style, that is think ergonomic. In microscope centered practice, training of the chair side assistant is paramount. If your assistant is not trained, your microscope dentistry is going to be more stressful rather helpful. And taking short breaks between the procedures, do some basic stretching. As I already said, health is the only wealth. So early we realize it is better. Magnification and DOM is the game changer. We have to understand it. And this is one thing. I have a message for the dental schools. They impart training the students under DOM from the initial part of their like even the BDS days will help a lot. So it's never too late to begin. And so here I come to my presentation. I share my cases under the hashtag EndoConcept. You can follow that hashtag and you can just keep a track of my cases. You can just follow my page on Facebook, the Micro-Endodontic Training Academy, and you can follow my YouTube channel at the rate EndoConcept. Thank you. It's over to you,
Very
sir.
well, very well presented, Dr. Saurav. Beautifully explained.
I think
Musculoskeletal.
I've not breached the time.
Not at all. You are very well in time, and you have very well, in a very concise way, you have covered all the topics that you wanted to cover, and you have beautifully shown all the lines of evidence you wanted to put across musculoskeletal disorders, presbyopia, importance of ergonomics, and the importance of including dental operating microscope in the dental curriculum, so that people can work for many more years, keeping their
Yes.
health, keeping their health as a priority. And so many postures you showed where people, if the posture is not maintained, how in the long run it gives rise to so many musculoskeletal disorders. And it was very, very informative, and we have already received some good feedback here. It was very informative. And let me ask some of the questions sent to us by the delegates who have registered for this webinar. Okay, the first one is, uh, what has been your experience with operating microscope when it comes to calcified canals?
When it comes to calcified canals, operating microscope is very helpful actually. As because in calcified canals, we know that the calcification happens only mostly in the coronal part of the canal. The rest of the apical canal is mostly patent. But to locate the orifice is very important. So if we have microscope, it helps us in many ways. For example, in vital tooth, in calcified cases, when we just clear of the bulk of calcification, we can make out red spots or the bleeding spots from the canal through the microscope, so we can easily pinpoint, we can operate in that area and open up the canal. So this is one way. So if suppose other way, like if the tooth is non-vital, in that case we can do a bubble test with sodium hypochlorite. So if we put sodium hypochlorite and keenly observe under microscope, we can see small bubbles coming out, and if we follow the bubbles, we can easily locate the orifices. So this things really helps in calcified cases. And in my experience, I have seen that calcified cases mostly comes in the vital state. So bleeding, identify the bleeding spot is very easy, and it really helps to open up the this thing. So just digging around and landing up in perforation of the floor or somewhere else, if you have microscope, it is very easy to locate a calcified canal.
Great. Uh, Two people have sent questions on loops. So the first one is, can loops help in avoiding forward bending, or you need microscope only?
Um, Actually, there is a basic difference between the loop and the microscope. So that is the confocal light. So if the microscope has a confocal light, that is the light uh, and the objective lens are in the same line. So in loops, most of the time there is some amount of uh, what do you call angulation of the line of vision and the light. So they are not exactly confocal. This is one shortcoming with the loops. The second thing is, now I think few loops have come which have longer like working distance, like 380 millimeters or 400 millimeters. So I think it may work, though I have not tried them. But there is a basic difference, like in loops invariably some amount of eye straining happens, as because like the image is very like the focusing is very constricted, so some amount of eye straining do happens in loops with whatever loop we use. In microscope, eye straining doesn't happen at all. If you just keep on blinking between your cases, you don't have to do anything else, just have to keep on sometime blinking, the most all of the problems solved. As because in microscope we see the image at infinity, always it's always at parallax. So the eye straining, there is no question of converging of the eye and straining. But in loops invariably there will be some amount of convergence, whatever type of loops you use, though few loops comes with that extended working distance, but the straining issue do remain there. So we cannot compare both of them. Loops is for short working, General dentistry, sometimes you have to see quickly, so it is fine, it is handy to like organize a microscope, position a patient, and like parfocaling is a bit time consuming compared to the loops. In such way, for quick short works, loops is fine, but for extensive long works, microscope is the must thing.
Beautifully explained. Beautifully explained. Okay. How to manage the view while working with files? Any tips
Ah,
on this?
okay, yes. There are. This is a very important question, and lot of material is not available. Though I think I'll just give one example. There is one endo holder. I don't want to take the names, but there is no other product, so I have to take the name. So, am I allowed to take the name, sir?
Yeah, you can. It will actually help the participants to.
Okay, sure, sir. So money comes with an endo holder. So you have files of different sizes like 10, 15, 20, 25. So the K files are there. So you can just have that. So what happens if we take a hand file and hold it with your fingers and take it? So it will block the vision under a microscope. Even under a loop also it will block the vision. So to keep away our fingers will actually enable us to see where the file is exactly working. So in that case, endo holder is a very good like tool. So you can have that. It is a off angle thing, so you can easily, it is like a dg probe, more flexible variety. So you can easily locate the canals and do the job, even take working length also with that, so it helps.
Great. Uh, Similar question, but this is about your tips for removing broken files using a microscope.
You see, tips for like when you are like some file is fractured, you need to remove it. First of all is the diagnosis, like where the file has fractured. You need to have a cbct in current times. So to locate the inner wall, the axial view is very important. You have to locate the inner wall first, and you have to be a master in operating the microscope. Retrieval of file is the most advanced thing that you do with a microscope, as because it changes all the spatial arrangement. You might be thinking you're going right, you may be going somewhere else. When you think you're going left, you might be going somewhere else. When you're thinking you're going down, you may be actually coming up. So entire spatial arrangement, when you work under the microscope, it changes. As because in microscope there is no direct vision, whatever you work is always in direct vision. So that is, you have to master the use of microscope first, then only you'll be able to retrieve files. And for that you have a lot of retrieval tips available in the market. You have kits also. And but the most conservative way of removing a broken file or a separated file from the endodontic canal is the ultrasonic technique. So where you use fine tips, ultrasonic tips, to create a gutter, 180-degree gutter around the inner wall of the file once you have exposed the coronal portion. And then you vibrate it with specific files to just pop up the file. It comes easily. Most of the time you don't need a graping device. It will just pop out with the irrigation or just your vibration of the ultrasonic, and it will be trapped in the rubber dam. So the baseline is that if you want to retrieve file with microscope, you have to master the microscope use first. That is important.
Okay, great. Two more questions on broken instruments. Situations where file can be retrieved through dental microscope and where not.
Um, this is a very good question. Most of the files can be retrieved through the dental microscope. Sometimes you have to make them visible, the coronal portion. Sometimes what happens, if there is a lot of curvature of the canal and the file has fractured exactly in the tip, so in that case it is completely retrieval, like blind retrieval, so you cannot see the file. But again, there also you have to work along the inner wall first to create a space for that file to come up. So if the file is directly visible, it is fine, it's easy. If the file is not directly visible, you have to like attempt to create a space so that the coronal end of the file is visible. And in the third case, you have to just precisely go along the inner wall, create space, make the file prop up a bit inside the canal, then it automatically becomes visible and you again retrieve it with the vibration. So even the completely non-visible file also at a stage is made visible to vibrate and come out of the canal.
Okay. Now there is a very interesting question here. Is it necessary to remove broken instruments always?
No, it is not necessary. Actually, I have an entire presentation on this one, like decision making in separated instrument. So I never thought this question will come up here. So it depends, like you have to decide at what stage of the canal preparation the file has separated. Was the file sterilized or not? What is the periapical conditions of the like the root or the canal in which the file is fractured? Sometimes, if you can suppose a file is fractured and there is a periapical pathology, and the file has fractured in the initial like time of the canal preparation, and you can like bypass the canal, bypass the file, and create enough a space so that you can easily irrigate and obturate sufficiently. So in that case, if the file is retained also, it may lead to healing. But if there is a periapical pathology, quite amount of periapical pathology, where we expect biofilms around the outer surface of the root canal, in such cases retrieval of the file is recommended if you are unable to bypass completely. So in that case the retrieval becomes mandatory. So that is how it happens. And if there is no periapical pathology and the fracture happens at a very later stage, you can just leave that file. It may not harm also.
Okay, great. Okay, Dr. Swati Singh, could you recommend the best quality microscope? There is another question on similar lines. One of the
Best quality microscope is actually, when it comes to quality, it comes with a price. So if you're able to pay the price, there are a lot of microscopes, much leading brands. So we can always have that, but they do come with a price and they're quite expensive gadgets. But if you want to have microscope in your clinic and start off, you feel motivated with this presentation, then you can investment of say around 7 to 10 lakhs will have your handsome microscope that will solve all your problems.
Okay, great. Mm, what is the percentage of success in microendodontics?
100%.
Great. Okay, so there is a question here, and it's all about blocked canals and cystic lesions. What is the alternative treatment for blocked canals with cystic lesions where RCT is troublesome? And how has been your experience with microendodontics?
You see, if a canal is blocked and I'm able to like make the canal patent or open it up completely, invariably that will uh, there is one way we can keep the case in observation. We can recall the patients 3 months, 6 months, 1 year, like that. If that is working, it is fine. If that is not working, then invariably you have to go for pulling out the tooth and go for any other prosthetic options that are available. But for a blocked canal in a lesion, there is a periapical lesion and the canal I am unable to negotiate. So in that case, there are only two options. One is, till wherever we can reach, let us do the maximum cleaning shaping possible, attain the biologic goal, and even you can obturate. I have to keep it concurrent that we need to keep the patient informed like what we are planning. So if the patient agrees, we can keep the patient on observation. I have few cases which has worked for years in that way. So I don't say that if you see a cystic lesion on a blocked canal, immediately remove the tooth. It is not like that. It really works many times. So cleaning shaping is the important thing till wherever you can reach, and we need to keep the patient on observation and follow up. So whenever it fails, so patient is already knowing that we can pull out the tooth and we can go for different prosthetic options. So that is the only way how it can come. And according to the experience of Micro-Endodontics, I say that it's really awesome.
Great, great. Okay. Is single sitting root canal treatment possible with microendodontics?
Single sitting root canal treatment and comparison with a microendodontics, I think the doctor wants to know, like, he or she might be thinking that microendodontics is a time consuming thing. I want to say that micronautics is not a time consuming thing if you have a trained assistant. That is the important thing. And if you are trained enough in using that microscope. Most of the people, they may have microscope, but they don't know the exact way of working with the microscope. That is again a bigger problem. So that will end up in like losing time between patients. But there is no link between a microendodontics or using a microscope and a single visit treatment. You can do anything with microscope with the same efficiency and same time as you do with an unaided eye.
Great. So there is another question. Do you do single sitting retreatments? If yes,
I
then when?
don't do single sitting on the, like, on the first go itself. I don't believe in single sittings. So there is
Okay.
no question of single sittings in retreatments.
Okay. Canal obturation done at which level?
I think the question means, when you are doing a root canal treatment, endodontic treatment, orifice sealing or the coronal seal is very important. And for a good coronal seal, you should have guttapulcus ended approximately 2 to 3 millimeters inside the orifices so that you can have resin blocks or resin plugs there. So it should end approximately 2 to 3 millimeters inside the orifice where you etch and you bond so that you have resin plugs and your coronal sealing is perfect.
Okay. Great. I think we have come to the last question. For new users, which company's microscope do you recommend?
As I said earlier, like, don't go for non-standardized microscopes that could be harmful to your eyes in a way or the other, as because you never know the optics, you never know the quality of the lens that has been given, as because the chromatic aberration, there is kind of aberrations in the lens, so those aberrations are minimum when you go for good quality microscopes. I don't say go for very expensive one, but as I said, for this thing, for initial thing, approximately some 7 8 lakhs, or say 7 8 to 10 lakhs, you'll get a good microscope with quality things that will not harm your body in any way.
Great. Your opinion on immediate endodontic sealing?
Immediate endodontic sealing. I'm not getting the question, sir. Immediate
Urvashi,
endodontic.
can you reframe your question? What you are trying to ask? Please reframe your question. I think this is going to be the last question of the session. If you can reframe it, put it in better words. Sealing dentinal tubules with bonding agent.
Immediate dentin sealing. Is
Immediate
it that?
dentin sealing. Yeah, yeah, yeah.
So immediate dentin sealing has nothing to do with endodontics. Is basically a conservative dentistry question,
Yeah.
but restorative dentistry. So immediate dentin sealing is a concept where we are going for extensive restorations of a tooth, uh, but like, there is a very deep cavity and it is presumed to be very near to the pulp. So to just protect the like percolation inside the dentinal tubules, a thin flowable resin is just flown on the dentin and it is sealed before you proceed to placement of clamp and other cumbersome things. So that is immediate dentin sealing concept, and it is recommended actually.
Okay. Irrigation solutions used in microscopic and microendodontics.
No difference. In microscope endodontics is nothing. Microscope endodontics is just the way you see into
Endodontics,
the
yeah.
canal is different. Otherwise, it is everything same.
Great, great, great. So I think that brings us to the end of today's session. Thank you, Dr. Sourav Banerjee, for taking out from your hectic schedule and sharing your knowledge with your vast experience with microendodontics, and also answering all the questions in detail. It was a pleasure having you here, and thank you all the viewers for joining in and making today's episode highly interactive. So that brings us the 21st episode to a successful conclusion. Soon we'll be announcing the 22nd episode and the topic and the speaker. So watch out our social media pages of ICP Health Products. We'll be putting up the details very soon. Any parting message, Dr. Saurav, to participants who are enthusiastic or the enthusiasts about microscope enthusiasts? Any recommendation?
So what I mean to say is, it's never late to begin. So always think in the long run. And just my closing statements will be: don't think microscope like all other gadgets. Don't think microscope as a return on investment. Microscope adds value to your practice. Once you start working with that over a period of time, patients will recognize that, and you will also feel like your predictability of your cases will go up slowly. So this doesn't happen overnight. Like, you have to work for 5, 7, 10 years in one way throughout, keeping one motto and one goal, and then finally at the end of a decade ends, you start getting the results. So it is a value addition, not only to your practice, even to your health. It is a good investment, and that will definitely fetch you results.
Thank you. Thank you so
Thank
much.
you. Thank you, sir. It was
Thank you,
nice.
thank you so much.
Thank you.
Okay, let us end the session. Good night, everybody, and
Good
let
night,
us
sir.
meet for the next episode. Thank you.